بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أعزائي أبنائي وإخواني وأخواتي الطلبة، في خضم سلسلة Ophthalmology Made Easy. محاضرة اليوم ستكون بخصوص Interpretation of OCT Map in Glaucoma. This lecture is targeting all postgraduate students in the ophthalmology department, as well as all junior doctors who's practicing ophthalmology in different hospitals. In this lecture, we will simplify how can we read the OCT map. We will start with the simple introduction of the principle of OCT and the evolution in the technology of OCT from the time domain to the spectral domain, and then swept source OCT. And finally, we will speak about the development of OCT angio. And we will discuss all these issues related to glaucoma, how we can interpret and follow patients with glaucoma using this technology. And at the end, we will discuss about establishing a progression analysis for glaucoma patients. I hope that you will benefit from these lectures and you will enjoy this lecture. And we will start with the first slides.
We will go through the chronological sequence of definition of glaucoma that has been changed over time. Because of the advancement in the early diagnosis of glaucoma, now there are different terminology is important or included in the definition of glaucoma. In 1960s, glaucoma just was defined as raised intraocular pressure with optic disc cupping and visual field defect. Then after that, they realized that visual field defect is a late sign, and you might find patients with high intraocular pressure and without visual field defect. So in 1980s, they defined glaucoma as an optic neuropathy characterized by optic nerve head changes, visual field changes, with IOP as a risk factor. And IOP as a risk factor to include the low tension glaucoma, that IOP elevation is not mandatory in cases of normal tension or low tension glaucoma. After that, with the emergence of the OCT at 2004, it was redefined as changes in the optic nerve head and nerve fiber layer, retinal nerve fiber layer. As a result, a characteristic damage to the ganglion cells will take place and leading to visual field changes. So from these different definitions, you can understand that there is no fixed definition for glaucoma, and it changes over time as the emergence of new categories of glaucoma, like normotension glaucoma and pre-perimetric glaucoma and glaucoma suspect, like this. So we will go through these definitions one by one. So the definition now, the current definition of glaucoma is a chronic progressive optic neuropathy. It is not a disease, it is a syndrome or a group of diseases characterized by progressive optic neuropathy associated with accelerated apoptosis of retinal ganglion cells, which result in retinal nerve fiber thinning with characteristic optic disc cupping and visual field abnormality that may or may not be associated with a rise in the intraocular pressure. So this is a very important definition, that it includes both the structural and functional changes in the patient with glaucoma. What I mean by structural changes, that is the changes that happens at the level of the retina, either retinal nerve fiber layers or in the macula, that's the ganglion cell complex, or at the optic nerve, that is the cupping and the thinning and the neuroretinal rim. And the functional changes will be reflected back into the visual field. So this is the final definition that every candidate of postgraduate in ophthalmology, he should memorize this definition. So he should include all the terms included in this definition. The other thing is the what's known as pre-perimetric glaucoma. What's the meaning of pre-perimetric glaucoma? This is characterized by the presence of glaucomatous changes in the optic disc and increased vulnerability to damage in the retinal nerve fiber layer without the presence of visual field changes detectable by the standard automated perimetry. So this is include just the structural changes without functional changes, that there is structural changes in the retina in the form of retinal nerve fiber layer abnormalities and optic disc changes like disc hemorrhages or increased cup disc ratio, but still at that time patient is not having any visual field changes. That is, the functional changes is not there. So this is termed as a pre-perimetric glaucoma. That's, he has glaucoma, but still he has no visual field defect or abnormality. The third definition is the glaucoma suspects. Glaucoma suspect, this is a stage earlier before the pre-perimetric glaucoma. In this term, any individual patient who exhibits risk factor that put him or them at higher risk of developing optic nerve damage or vision loss due to glaucoma is defined as glaucoma suspects. However, the definite diagnosis of glaucoma is not confirmed, but also cannot be excluded at the time of the consultation. Now, we speak at the level of no structural changes and no functional changes, just the patient has the risk factors only. I mean, he has completely normal optic nerve, completely normal retinal nerve fiber layer, and the ganglion cell complex are completely normal, but this patient is at high risk because of positive family history, or he has ocular hypertension, or he's has relatives with glaucoma, or he's from black races. Like this, patients are named as glaucoma suspects. So we shouldn't neglect these patients. We should follow them serially so that we pick up them early. If they convert to pre-perimetric glaucoma, then they convert to glaucoma. So you can see that this is a spectrum, large spectrum of glaucoma, starting from glaucoma suspect and end up with glaucoma itself. In between is pre-perimetric glaucoma. As we mentioned earlier, that early detection is an important task that you have to do for prevention of glaucoma. So if you diagnose glaucoma early, you can treat it early. And if you treat it early, you can slow the rate of progression. And if you slow the rate of progression, you can prevent the blindness. Now, what's the impact of glaucoma? As you know, glaucoma is the second most leading cause of blindness worldwide. If you can see, the most common cause of blindness is cataract. If we speak about both reversible and irreversible causes of blindness, the most common cause of blindness is cataract, and the second most common is glaucoma, followed by age-related macular degenerations, and then diabetic retinopathy and corneal scarring. Now, if we speak about the most common causes of irreversible blindness in the developed countries, age-related macular degeneration is the most common, and in the developing countries, diabetic retinopathy is the most common. However, if we speak globally about both the reversible and irreversible, the most common cause of blindness is cataract, followed by glaucoma. And the importance of glaucoma that it is reversible and silent and no symptoms. That's why it's named as silent thief of vision. It's the silent thief of vision. And hence the quick actions for early detection and prevention is very mandatory for prevention of blindness. As far as the predisposing and risk factors of glaucoma, as you know, the main risk factor and the most important risk factor for the development of primary open-angle glaucoma is the elevated intraocular pressure, as seen in the ocular hypertension study, followed by family history, that is hereditary, or some hereditary factors are seen in the patients with glaucoma, as 10% of the siblings and 4% of the offsprings of the patients of primary open-angle glaucoma, they have high incidence of developing glaucoma. And among a lot of genetic study has been conducted, there are three main gene prototypes have been determined. That is the myosilene location gene, and the optoneurine gene, and the WD domain 36 genes. These are the three main types of genes that have been identified in association with patients of glaucoma. Another risk factor is the age. It is found that the 5th and 7th decade, they have increased risk of glaucoma. So people with beyond the age of 50, they have to have a regular checkup for their intraocular pressure. The other risk factor is the race. They found that open-angle glaucoma is more common in blacks, and not only just the the incidence or the prevalence common in black, but also the onset very early, and the disease is refractory to treatment. And among the refractive errors associated with the glaucoma is the myopes. Myopic peoples are more prone for open-angle glaucoma. Another important risk factors recently determined is the central corneal thickness. They found that the thinner the cornea, the more incidence of developing open-angle glaucoma. Although the decrease in the corneal thickness will make error underestimation of the intraocular pressure, and this can lead to delayed diagnosis of the disease. But they found a close association between the decrease in the corneal thickness and the onset of glaucoma, and this can be attributed due to the same factors affecting the cornea will be playing back in the lamina cribrosa and affecting the optic nerve. Now, among the systemic association or systemic diseases, diabetes, hypertension, and Graves' disease. Although there is a lot of debate and a lot of controversy about the association of diabetes and hypertension, they found increased incidence of glaucoma in diabetic patients and in hypertension and Graves' disease, but the exact mechanism is not known. But the most likely playing factor may be related to what's called the perfusion pressure of the eye. What I mean by the perfusion pressure is the difference between the diastolic blood pressure and the intraocular pressure. The diastolic blood pressure and the intraocular pressure. If the perfusion pressure of the eye is below 55 millimercury, this will increase the incidence of the glaucomatous damage into the eye. However, still there are some studies that says that they found no association with diabetes and Graves' disease. Also, the same for cigarette smoking. It is found that there is association between cigarette smoking and increased intraocular pressure. Now let's talk about the theories behind the glaucoma. What's the exact mechanism playing in glaucoma? As you know, and in our traditional teaching for students in the 4th year, we used to say that there are two playing factors responsible for the glaucoma. That's the mechanical theory and the ischemic theory. And the mechanical theory is named as IOP related or IOP dependent. And the ischemic theory is ocular blood flow. That's the perfusion pressure dependent or related. And this ischemia or low perfusion will lead to a decrease in the exoplasmic transport of the nerve fiber layers and lead to what's named as neurodegenerations. Other thing, this will lead to apoptosis to the ganglion cells and consequently damage to the nerve fiber layers. Another playing factor is the genetic theory, as we mentioned earlier, that there is some genetic loci has been identified in association with patient with glaucoma, what's called myosilene associated glaucoma, which is seen in 4% of the primary open angle glaucoma in adult onset and in 10% in juvenile onset or congenital glaucoma, mainly in congenital glaucoma or adult onset glaucoma. Now, there are other factors responsible for glaucoma or other mechanisms have been suggested other than the mechanical theory and the ischemic theory, like named as non-IOP dependent mechanism, like reduced ocular perfusion pressure, excitotoxic damage from excessive glutamate, autoimmune related nerve damage, and loss of neurotrophic factors, and failure of cellular repair mechanism and abnormal autoregulation. All these are proposed as another alternative mechanism of glaucomatous damage in patient with glaucoma. In the picture on the right side, you can see clearly the normal optic nerve and the normal blood supply and the nerves. And when there is ischemia, there will be increase in the cup atrophy and apoptosis of the ganglion cells and nerve fiber layers, and hence lead to the cup formation, as you can see here. The same thing for the increase in the intraocular pressure. This will exert pressure on the lamina cribrosa in the pores of the lamina cribrosa, and this will lead to atrophy of the nerve fiber layer and leading to cup formation. In this cross-section of the optic nerve, we will speak about the mechanism of glaucomatous damage of the optic nerve. As you know, and as we mentioned before, that there are main two theories, mechanical and ischemic theory. Now, the mechanical theory explains the damage that happens in the optic nerve due to elevation of the intraocular pressure. Now, if you can see here in the cross-section of the optic nerve, that the fibers of the nerve fiber layer, when they want to exit the eye through the optic nerve, they have an acute course, nearly a right angle, and they pass through small pores of the lamina cribrosa with a little connective tissue in between. The theory states that when there is an elevation of the intraocular pressure, there will be exerted pressure on these pores, and this lead to in turn lead to cessation of the exoplasmic transport, and after that lead to death of the axons of the ganglion cell layer, and hence the optic nerve damage will take place. This is the mechanism of the mechanical theory, and as I said, the mechanical theory explains mainly the damage that happened due to elevation of the intraocular pressure. Now, this theory cannot explain the damage that happens with normal or low intraocular pressure, the so-called normotensive glaucoma or low tension glaucoma. Now, if you see in this slide, this is a cross-section of the eye showing the parts of the optic nerve, the intraocular part, which is around 1 millimeter, the shortest part, and the intraorbital part around 25 millimeter, and the intracanalicular part around 9 millimeter, and the last part is the intracranial part, which is around 16 millimeter. If we take a cross-section over this area, that's the optic disc only, this slide, as you can see in this slide, it is further subdivided into nearly 4 parts based on its relation with the lamina cribrosa into a superficial nerve fiber layer. This is the most superficial part that we see with direct ophthalmoscope, and prelaminar part that's before the lamina cribrosa, and the laminar part that's at the level of the lamina cribrosa, and the retrolaminar part that's the part behind the lamina cribrosa. As far as the blood supply, nearly the first layer, that's the superficial most layer, and the last layer is supplied by the central retinal artery. You know that the optic nerve has a double blood supply. That's from the ciliary retinal artery and from the ciliary circulations. So the first layer and the last layer is supplied mainly from the central retinal artery. However, the intermediate layers is supplied by circle of Zinn, a plexus, arterial plexus of circle of Zinn from the long posterior ciliary arteries, So this cross-section shows the anatomy and the blood supply of the optic nerve. Now, the ischemic theory says that when there is decrease in the perfusion pressure of the eye, this will lead to damage to the axons of the nerve fiber layer or the axons of the ganglion cells. The perfusion pressure is the difference between the intraocular pressure and the arterial pressure. If the arterial pressure is low, so this will lead to decrease in the perfusion pressure, and in turn will lead to glaucomatous damage or ischemia to the optic nerve fibers. The same thing regarding the cerebrospinal fluid. As you know that the optic nerve once leave the sclera and go to the intraorbital part and then to the intracranial part, it is surrounded by the meningeal sheath, and there is a subarachnoid space filled with CSF. And the theory says that when there is decrease in the pressure inside the eye, with even normal CSF pressure or a little bit high CSF pressure, this will create a pressure difference across the optic nerve and across the lamina cribrosa, and this will lead to ischemia and damage to the optic nerve. This is the main points of the ischemic theory. So we have 2 theories, the mechanical and the ischemic theory, that explains the mechanism of glaucomatous damage in the optic nerve. Now, in continuation to the mechanical theory, now this is the portion of the optic nerve. If we have a cross-section of the optic nerve, that's the intraocular part. You can see that there is 4 parts of the intraocular part of the optic nerve. That is the superficial layer, that is the facing the eye, that's the area of the optic disc. Then the prelaminar part, that's before the lamina cribrosa, which lies at the level of the choroid, and the laminar part, which is at the level of the sclera. That's the lamina cribrosa, and the retrolaminar part that is exiting from the eye. Now, if we have a cross-section throw at the level of the lamina cribrosa, you can see clearly the pores here in the other slide. If you can see here, this is the pores here in the superior temporal and inferior temporal. There are large pores with minimum interconnecting tissues. So this make this area very susceptible to the elevation in the intraocular pressure, leading to kinking and cessation of the exoplasmic transport. And in turn, this will lead to apoptosis and death of the ganglion cells. This is the mechanism of the mechanical part of glaucoma. Okay. As far as the blood supply of the optic nerve, you know that the optic nerve has a dual blood supply. It has a blood supply from the central retinal artery, which is a branch of the ophthalmic artery, and a blood supply from the posterior ciliary artery, which is also a branch of the ophthalmic artery. Now, in this slide, you can see clearly this is the ophthalmic artery. As we said, that we have four parts of the optic disc part: the surface nerve fiber layer, the prelaminar layer that's at the level of the choroid, and the laminar part, which is at the level of the lamina cribrosa, and the retrolaminar part. Now, the central retinal artery supplies the first part, that's the surface nerve fiber layer, and the last part, which is the retrolaminar part. Okay. Now, the posterior ciliary artery, which is also branch of the ophthalmic artery, will form a plexus that is the circle of Zenov-Haller, which supplies the prelaminar part of the optic disc and the retrolaminar part of the optic disc, and also some branches goes to the retrolaminar part. Okay, this should be clear. And also the posterior ciliary artery, through the short posterior ciliary arteries, will also supply the choroid to the peripapillary capillary plexus. Okay, so this is also the representation here. This is the ophthalmic artery versus the optic nerve, and go as a central retinal artery, and supplies the surface part and the retrolaminar part. And this is the posterior ciliary arteries, form the circle of Zen of Haller, and supplies the prelaminar and retrolaminar, prelaminar and laminar part of the optic disc, and some branches also goes to the retrolaminar part. So this should be very clearly understood. So to understand what will happen to the optic disc in different diseases, for example, ophthalmic artery occlusions or anterior ischemic optic neuropathies or any glaucomatous damage due to ischemia. Among the things that I want to revise with you before we go in deep level studying the OCT, that there is what's called isn't rule. Isn't rule means that the inferior part of the neuroretinal rim is the thickest one, followed by the superior part, then the nasal, and the last one is the temporal part of the neuroretinal rim. And the shape of the optic disc normally is horizontally oval, and this respecting the isn't rule. Now, if the isn't rule is respected, you will find the cup that is horizontally oval. However, if you find a vertical oval cup, this indicates that there is thinning of the inferior or superior pole, and this means that the isn't rule is not obeyed, and at that time your patient is suspicious glaucoma. It is very important to concentrate on the neuroretinal rim rather than the cup. The cup is a variable. The cup is not a very important or fixed landmark in the diagnosis of glaucoma, because it is variable. You can find a small cup as 0.4 or 0.3 or 0.2, and it is a glaucomatous cup because of the small optic disc. And you can find a large cup of 0.6 or 0.7, and it is normal cup because of large optic disc. So the size of the cup is variable and is related to the size of the optic disc. So it is not a fixed landmark to concentrate while you are diagnosing glaucoma. However, the neuroretinal rim is much more specific and sensitive indicator of glaucoma. And the other thing that in glaucoma, the inferior and the superior poles of the neuroretinal rim are the most vulnerable parts of the neuroretinal rim that is first to be affected in glaucoma. And this can be explained by the fact that the arcuate fibers that converge to the superior and inferior poles are much more vulnerable to glaucomatous damage, because in the superior and the inferior pole, the lamina cribrosa, where the fibers of the optic nerve will pass, they have large pores. And these large pores with minimum or little glial tissues or connective tissues, so that when the axons of the ganglion cells converge in that area and they get bent, with any increase in the intraocular pressures, they will exert pressure in the nerve fibers, and they lead to cessation or stop of the exoplasmic transport, and in later stages lead to death of the nerve fibers. So because of the large pores of the lamina cribrosa, the superior and inferior parts, so the glaucomatous damage is much more common in the superior and inferior parts of the neuroretinal rim, which receives the arcuate fibers from the retina. That's why it is commonly the first area to be affected is the inferior, followed by the superior pole. That's why we have to concentrate in this area. As I mentioned, when you see this picture, this is the normal shape of the optic nerve. You can see that the vertical diameter is around 1.8 millimeter and the horizontal is 1.7 millimeter. This makes the optic nerve is a little bit oval, vertically oval. This is the normal, vertically oval. However, the optic cup is horizontally oval. This is normal, as you can see here and also in this picture. This is the normal optic disc, and this is the optic cup. So the disc is vertically oval and the cup is horizontally oval. Any change in this make the optic disc more suspicious. For example, in a glaucoma, you will find the cup becomes vertically oval. So this is more suspicious. And why it is vertically oval? Because it violates the isn't rule. That is, normally this is the inferior pole is more thicker than the superior pole. So when there is a enlargement of the cup and there is violation to the inferior pole, now the isn't rule is not obeyed. So at that time, it makes the optic cup more vertically oval and will be changes in the thickness of the inferior and superior pole. Okay, so this is called is not obeying the isn't rule or violation to the isn't rule. In this slide, I will say a few words about the methods of clinical examination of the optic nerve. Although the advancement in the technology of imaging of the optic nerve and the development of many machines like the OCT and the GDX and also the functional machines like the perimetry, but still the examination of the optic nerve remains the gold standard for any assessment or diagnosis or follow-up of a case of glaucoma. And that's for many reasons. Number one, that these machines are subjective to artifacts, either due to the imaging techniques or the segmentation. And also these machines depends on the comparison of this data taken from the patient with the normative data. Now we have problem with the normative data that most of the machines, they don't include, for example, patients with high refractive errors like high myopia who are at risk of developing glaucoma, and also the normative data is limited for young patients. Also, these machines are subjected to existing morbidity, for example, the presence of epiretinal membranes or posterior vitreous detachment. So even the recommendation of the European Society of Glaucoma, the 5th edition, they recommend that glaucoma cannot be diagnosed only by the OCT. It should be used as adjunctive OCT, and the imaging technique should be used as adjunctive tools to the clinical examination. So the examination of the optic nerve and especially the optic disc is very mandatory as a tool in the diagnosis and follow-up of patients with glaucoma. So among these methods is the cup disc ratio, which is invented in 1960s by Marley, and it becomes very famous and popularly used as a tool for assessing and differentiating between normal optic nerve from glaucomatous optic nerve. The disadvantage of this method that it is a subjective test and it is subjected to a very high degree of observer and intra-observer agreement variability. And the other thing that it doesn't include the optic disc size and the position of the cup The other famous, this is after 20 years, after 40 years, around 2002, the Spaeth et al. Has invented a new technique of assessing the optic nerve, that is the disc damage likelihood scale. And this method based on the narrowest width of the rim, the radial width of the optic nerve rim, compared to the total disc size in the same axis. So it is named as rim to disc ratio instead of the cup to disc ratio. It is called the rim to disc ratio. It has the advantage that it takes into account to the location of the cup and take into account the size of the optic disc, and even the places where there is no neuroretinal rim. It measures the in degrees how much the area of missing optic nerve rim. So this technique has been found to be highly reproducible, and it is greatly correlated well with structural and functional tools like perimetry and OCT and other methods of optic disc imaging. And that's why it is now much popularly used rather than the cup disc ratio. The disadvantage or the limitation that it has, or it needs a learning curve. It needs a learning curve. So I would like to send a message to the junior doctors and practitioners who are practicing in different hospitals to concentrate and try to learn this method or this scale, so that you will not under or overestimate glaucoma. It is more useful and more reproducible as compared to the cup disc ratio. So try to concentrate on this method. This grade system or scale system made up of 10 stages. So it gives you an opportunity to stage your patient and stage the optic disc and find out the patient at what stage of the disease. And it is, as you know, also in pre-perimetric glaucoma, the structural changes that happens to the optic disc can happen before even the perimetry appears. So examination and applying this scale also is very useful in early detection of glaucoma as well. Since the cup disc ratio is not a sensitive parameter to determine the glaucomatous damage for many reasons. For example, if you look in this picture here, you will find two optic discs with the same cup disc ratio, but the eccentricity of this cup and the absence of the neuroretinal rim here make this optic disc is more in favor of glaucoma rather than this one, although they have the same cup disc ratio. So if we just depend on the cup disc ratio, we will miss many cases of glaucoma. However, now there is a talk about the rim disc ratio rather than the cup disc ratio. We will explain in the next slides how to determine the rim diameter and also the hypothesis behind the rim disc ratio. Another thing, the cup disc ratio doesn't take in consideration the size of the optic disc, and it might be of some use in concentric cupping. When there is concentric cupping, it has some importance. However, in eccentric cupping, it is may lead to misdiagnosis or loss of a lot of cases of glaucoma. It may be seriously misleading when the loss of the rim is limited to a single sector or with focal notching, as in this case. Okay. This slide shows how we determine the rim disc ratio. That's the radial diameter of the rim in relation to the diameter of the optic disc in the same axis, the radial diameter. So we will measure this area and divide it by the total diameter of the optic disc in the same axis. Okay, this is the rim disc ratio rather than the cup disc ratio. All of you know the importance of the relation of the cup to the optic disc. For example, this is two optic discs with the same cup disc ratio. However, one is central on the left side, and the other one is eccentric or notching. This is eccentric or notching, and this is in the central. So this one is more suspicious for glaucoma as it is irregular and notching as compared to the other one. So it is very important to find out the location of the cup in relation to the optic disc. This is one of the disadvantage of the cup disc ratio, that it doesn't take in consideration this relation and make the importance of the rim to disc ratio rather than the cup disc ratio. In this slide, I will emphasize on certain important points regarding the neuroretinal rim. In the assessment of the neuroretinal rim, we should concentrate on the color and the configuration to be able to differentiate the changes that's seen in the optic disc. Is it due to glaucoma or non-glaucomatous optic atrophy? An important fact that pallor of the rim suggests non-glaucomatous optic atrophy. So in glaucoma, usually glaucoma is not associated with pallor of the optic disc. Pallor indicate that there is abnormality of the optic disc or any optic neuropathy, but not due to glaucoma. In glaucoma, you will find thinning of the neuroretinal rim, but not necessarily you will find pallor. And actually what you see in white color is the base of the cup. When there is advanced cupping, the base of the cup will appear white due to lamina cribrosa. So you think that there is a pallor of the optic disc. And actually this is not the pallor of the optic disc. When you say pallor of the optic disc, you concentrate on the surface of the neuroretinal rim. So if you find pallor of your optic disc, it means that you have an optic neuropathy, but not necessarily due to glaucoma. The most specific sign for glaucoma is thinning of the neuroretinal rim. However, if you find any optic neuropathy with thinning of the neuroretinal rim, this is in favor of glaucoma, not other neuropathies. So pallor of the neuroretinal rim were found in 94% specific for non-glaucomatous optic neuropathy. However, focal or diffuse obliteration of the neuroretinal rim found in 87% specific for glaucoma. So I will repeat again. For glaucoma, confirmation and specificity for glaucoma, thinning of the neuroretinal rim. Pallor is not a feature of glaucomatous optic cupping. Pallor is a feature of optic neuropathy. Now, because of the fact that I have mentioned regarding the instability of the cup disc ratio in the assessment of glaucoma, as I said that you might find a cup disc ratio of 0.7 and still the patient is normal, and a cup disc ratio of 0.2 and the patient is glaucoma, because the cup disc ratio is related to the cup size, the disc size. So now doctors are using the new scale, that is the disc damage likelihood scale. This scale has been invented by Professor George Spaeth in collaboration with others and developed this scale system that's mainly dependent on the rim disc ratio rather than the cup disc ratio. We will go slowly and explain about this rim disc ratio in details. So this grade or staging system made up of 10 scales from 1 to 10, and it take in consideration the optic disc size. So the first thing, it divides the patient to 3 categories with normal optic disc size between 1.8 to 2 millimeters, and those category with large cup size that's more than 2 millimeters, and those with the small cup size less than 1.25 millimeters. And each one of these category is divided based on the rim disc ratio. The first 4 categories are patients are at risk, and the middle 4 patients are patients with glaucoma, and the last 2 or 3 stages are patients with advanced glaucoma. In the first 4 stages, it depends on the rim disc ratio from 0.4 to 0.3 to 0.2, then 0.1. From stage 5, now there will be no more rim. So the rim will be equal to 0. So in this stage and beyond, he depends on how many degrees the absence of the rim occupying the disk. So is it 45 degrees absent the rim, or 90 degrees, or 180 degrees, and so forth. So the first 4 stages, it depends on the rim disk ratio, and after that, since there is no more rim, so it measures how much the extent of the absence of the rim in degrees. So in this scale system, we should measure the rim at the thinnest point. Now, this is an important point. Not any part of the rim that you measure and bring the ratio of the rim disk ratio. No, you should measure the thinnest point of the rim disk ratio, the thinnest point of the rim thickness relative to the horizontal diameter of the optic disc in the same axis of the thinnest point of the rim width. So this is the disk damage likelihood scale is more reliable, more reproducible, and they found that it is also corresponding to the visual field changes, that when you find a patient with larger stage, you will find significant changes in the visual field. So it is since there is a numerical data, it is more useful in the diagnosis as well as in the staging of glaucoma. So as I mentioned in the previous slide, as you can see that the scale system of this disk damage scale likelihood scale, the first 4 categories define patient at risk when there is the rim disk ratio between 0.4, then declines gradually. So these patients are at risk. Now the other 3 stages, it signifies that the patients already they have glaucoma. Now here there is no rim disk ratio, 0.1 only, then 0. After that, we depends on the how much degree of the lost or 0 disk rim disk ratio in degrees, 45 degrees or 45 to 90 degrees or 90 to 100 degrees. And after the last 3 stages, it signifies that the patient has severe glaucoma. As you can see here in the pictures, that hardly you can see any rim in this optic disc. So this is very useful tool for quantifying the severity of glaucoma, as well as following up the progression, and make a strong structural functional relationship between this changes in the optic disc as well as with the visual field. So this is also the colored graphic scale of glaucoma staging. Again here, you can see this is the rim, which is eccentric. Now this is eccentric cup with absent rim here occupying 30 degree, this absent rim occupying 100 degree, this absent rim occupying 106 degree, and so on. So this is the angle of 0 degree occupying the rim disk ratio. So we depend on the thinnest point of the rim, and we, if there is no rim, we measure the degree of absent rim occupying the optic disc. This is the principles of the disk damage likelihood scale. This is some important references for those who are interested in this scale that you can read about this, and there are a lot of informations as far as the relation with the visual field and the importance of this scale as compared to cup disk ratio. So it is superior, this rim disk ratio is superior to cup disk ratio in many aspects. Okay, the previous slides was a brief introduction to the terminology used in glaucoma and the different definitions and the different clinical ways of assessing a patient with glaucoma. Now we will go to the main subject of this lecture, that is the OCT. We'll give introduction to the OCT, then we will go deeper and deeper till we end up with the interpretation of the map of the OCT. Here we will go quickly through the different types of commercially available OCT in the markets. The first OCT appears is the time domain OCT around 1991, followed by the spectral domain and then the swept source. Generally, the main principle of optical coherence tomography is based on the constructive interference of the wave. When 2 waves are propagated in phase, they undergo constructive interference. And when they are propagated out of phase, there will be a destructive interference. Now, this is the representation of the time domain OCT, that we have a monochromatic light, and this is a split beam splitter that split the light to two portions. One go to the eye, that's the sample, the rays to the eye, and this is the reference mirror. Now, when the rays are reflected back, that's the sample rays from the eye and the rays from this reference mirror, both of them will be propagated, and constructive interference will take place and then detected by the detector here. This lead to displaying high resolution of the tissue that is reflecting the rays. This is the main principle of the time domain OCT. So it is based on a monochromatic light and a moving mirror. However, when we look to the Fourier domain, instead of the monochromatic light, they use a broadband beam of light that contains all the spectrum of the rays, and then the same thing, the rays will be displayed, reflected to the eye and to the sample reference mirror, and the rays reflected will be detected by a spectrometer based detector, and then constructive interference takes place and display the image. Now, the difference in the spectral domain OCT, that is, all the rays reflected from all the layers of the retina will undergo this constructive interference and then can be displayed with high resolution. Unlike the time domain, that only the rays which lies in phase with the optical path of the reflected sample rays, they will undergo constructive interference. However, the other rays will be omitted and neglected. But in the Fourier domain, all the reflected rays will be undergo constructive interference. The other difference is the light source. It is using a broadband light source instead of monochromatic light. Again, this is a demonstration of the time domain OCT. Simply, it shows the light source. This is the coherent light source that emits light to the mirror. This is a moving mirror that reflects the rays to the eye, and this is another arm, that's the reference arm. Now, the coherence or constructive interference happens only when both the reflected rays and the rays from the reference arm, they having the same optical path. When they have identical optical path, at that time the constructive interference will take place exactly here. So this is the mirror, and it is moving so that it matches the optical length of the reflected rays. In the swept source OCT, it is same like the spectral domain OCT, but the light, we use special broadband light, but with tunable light source, that's laser, that emits a light with different wavelengths from the beginning, like the spectral domain that it undergoes split later on. However, in the swept source, from the beginning, the light is already split into a different wavelengths from a special source called tunable light source, that's laser, and all passes through the same stages as spectral domain, that's a reference arm and the sample arm, and the reflected rays will interfere and undergo constructive interference and picked up by the Fourier special detector. And then all the reflected rays will be displayed. All the reflected rays will undergo interference and be displayed, so that each layers of the retina will be displayed based on the spectral sensor. This slide shows the main difference between spectral domain OCT and swept source OCT. As I mentioned earlier, in the spectral domain, here the light is split into different wavelengths during the detection phase or stage. But initially the light is broadband. However, in the swept source, the light source is not a broadband. It is split from the source. So the light already split to different wavelengths. Then it goes inside the eye, and when reflected back detected by a Fourier transformer, and then it undergoes constructive interference. This is the main difference between swept source and Fourier domain OCT. There is two important terminology that we use to face in when we speak about the OCT machine. That's the axial resolution and the lateral or transverse resolution. Now, the axial resolution refers to the ability of the system to detect the difference in between or the distance between two reflectors parallel to the rays. So the difference between this reflectors and this reflectors, if the system can able to detect, so this means that these 2 points are resolved, so we can see them like this picture. This is the axial resolution. However, if the system cannot detect this distance between these two reflectors, the image will appear like this. So this is the image of the axial resolution. The other one is the lateral or transverse resolution, the same thing, that the ability of the system to detect the distance between two reflectors perpendicular to the rays. Now, if these two reflectors are very close together, so that there is no rays passing between, or the width of the beam is broad, so that can detect them as a one object, it will demonstrate the image like this. Can detect as a one reflectors. However, if the distance between the two reflectors is enough to allow for the beam to pass in between them, so we can see them as a two reflectors, separate two images like this. So this is two important terminology we should know. Now, as far as the axial resolution, it is dependent on the wavelength of the light source, and the shorter the wavelength, the higher the resolution. And to get a short wavelength, we have to increase the frequency of the rays. So increasing the frequency will lead to shortening the wavelength and give us a high resolution, but this in the expense of the penetration. When we increase the frequency, the penetration of the rays will be less. So we have to compromise one on the other. What's your priority? If your priority to have a high resolution, so you have to increase the frequency to have a good axial resolution. And if you want to have a good penetration beyond the retina and you reach up to the choroid, so you shouldn't increase the frequency, but you should decrease the frequency to have a better penetration. And this is one of the difference between Fourier domain and the swept source light, that in swept OCT, it has a good penetration. However, in the Fourier domain, it is lesser penetration as compared to the swept source. Okay. So in conclusion, we have two important parameters affecting the efficiency of your OCT machine. That's the axial resolution, also known as the longitudinal resolution and the depth resolution, and the lateral resolution, and also is known as transverse resolution and angular resolution. So by increasing the frequency of the light source, we can improve the axial resolution and as well as the lateral resolution to some extent. But this will be on the expense of the penetration deeper to the tissues. As we increase the frequency, the wavelength will be less and hence the penetration will be low. And the lateral resolution is not much dependent on the wavelength, but it is dependent on the width of the beam. The width of the beam. The smaller the numerical value of the width of the beam will be, the better the resolution. But in general, increasing the frequency will improve the axial as well as the lateral resolution. But still, we will face a problem with the depth penetration. And this is among the main differences between the Fourier domain OCT and the swept source OCT, that in the swept source, we have a better penetration and deeper penetration as compared to the Fourier domain OCT. So that in swept source OCT, we can image the whole eye from the anterior segment up to the retina by the single scan. However, in the Fourier domain, we cannot. If we concentrate on the anterior segment, we cannot capture the retina because the penetration is less. However, in swept source, we can have a complete picture of the eye from the anterior segment to the angle, to the vitreous, and then to the retina. Now, another important question arises, that is spectral domain inferior to swept source OCT, or is swept source better than spectral domain OCT? The answer for this question is not. because there are some variables that we need to discuss before for each one. Each one has advantage in particular aspect. For example, from the technical point of view, the spectral domain uses a wavelength of 850 nanometers. However, the swept source using 1015 nanometers, and the depth and the penetration of the swept source is much better than the spectral domain. However, the axial resolution of the spectral domain is better than the swept source. Now, the smaller the numerical value of this resolution means better resolution. And the speed of acquisition of A scans is nearly the same. We can reach up to 100,000 A scans per second. And so as the penetration is more, the sensitivity and the resolution will be less. However, there is another aspect, that the cost. The swept source is much more expensive than the spectral domain OCT. And for the spectral domain, there is good available normative data for patients. However, for swept source, we lack the normative data to compare the patients. And the swept source is superior to spectral domain in some aspects. For example, in cases of high myopia, in which the scan width and the scan depth is very important, because as you know, especially in the cases of posterior staphyloma. So studying the pathology of myopia is better with the swept source. Also in the presence of medial obesity, especially in cases of post-vitrectomy and there is gas injected inside the eye. So the immediate post-op period for detailed visualization of the retina, the swept source is much better than spectral domain. Another advantage of the spectral domain is the choroidal pathology, the presence of choroidal pathology, and the details examination of the zones and the lamellae of the choroid. Swept source is superior. Also, to some extent, swept source is superior to spectral domain in OCT angio. Those OCT angio based on swept source OCT has better segmentation and better in-fast images for OCT angio as compared to spectral domain. However, the resolution, the axial resolution of the spectral domain OCT is still much better than the that for the swept source OCT, and the cost of the spectral domain is less than the swept source OCT. This slide shows the difference, the different A scans or the different images that we can acquire from the OCT. This is the A scan that is in one direction, X or Y, and this is a B scan if we take the image in two axes. However, if we take it in three axes, it is called volumetric data or C scan. And this is the in-face image that we segmentally take a subsurface image of the retina. This is called in-face image. So this is the P scan and this is the in-face image. Before I go deeper to jump to the reading of the map of the OCT, there are certain factors that I would like to emphasize on. We have what's known as topographic analysis of the retinal nerve fiber layer and peripapillary or circumpapillary analysis of the retinal nerve fibers. Now, topographic analysis means that we assess the retinal nerve fibers on the surface of the optic nerve. And circumpapillary analysis means that we assess the retinal nerve fiber thickness in an area of 3.4 millimeter around the optic nerve. And also, we can assess the thickness of the what's known as a GCIBL thickness, that is the ganglion cell inner pixiform layer thickness. They found that the topographic analysis of the retinal nerve fiber layer and the analysis of the GCIBL thickness is more informative than the circumpapillary retinal nerve fiber layer thickness analysis to detect the optic nerve damage in glaucoma. So topographic analysis of the optic nerve is more informative than the circumpapillary retinal nerve fiber analysis. However, the retinal nerve fiber layer analysis assessment is more sensitive than the RIM assessment. Now, in generally, the retinal nerve fiber thickness analysis is more informative and more sensitive than the RIM assessment for the detection of the optic nerve damage by glaucoma. However, the RIM assessment is more specific than the retinal nerve fiber layer assessment to confirm the diagnosis of glaucoma. So please concentrate on these points. I don't want you to be confused. Now, they found that the neuroretinal RIM is specific for glaucoma. There is no disease that can lead to thinning or decrease in the thickness of the neuroretinal rim except glaucoma. If you find your patient with decreased neuroretinal rim, this is definitely a case of glaucoma. However, retinal nerve fiber thickness can be reduced or damaged or changed in many diseases, including glaucoma. So it is not specific for glaucoma, but it is more informative, more sensitive to tell you that there is some abnormality in the optic disc. You understand what I mean now? So just merely finding abnormality in the thickness of the retinal nerve fiber layer, either circumpapillary or topographically, this doesn't mean that your patient is a glaucomatous patient. It means only that this patient has abnormality in the optic nerve, either because of any disease, ischemia, or venous occlusion, or anterior ischemic optic neuropathies, or any other insult that lead to the damage of the optic nerve. But this doesn't necessarily mean that he has glaucoma. If you want to confirm, look for the neuroretinal rim. If you find reduction or beyond the normal average reduction of the neuroretinal rim, now this means that your patient is glaucomatous. And that's why in recent OCTs, they include a wide range of OCT that include both the macula and the optic nerve in the same map, so that you can study the decrease in the thickness of the nerve fiber layer in the macular area coincides with the changes in the optic nerve, so that it gives you more information about the pattern of the loss of the nerve fibers that's confined or coincides with glaucoma. As you know, glaucoma has a special form of retinal nerve fiber loss that is shape that is symmetrical with the trajections of the nerve fibers. So in a wide field OCT gives you more information about the changes that happens in the macula and coincides with the changes in the optic disc. So to sum up what I said, topographic analysis of the retinal nerve fibers is more informative than peripapillary analysis of the retinal nerve fibers. Both topographic and ganglion cell IBL analysis is more informative, and for specific diagnosis of glaucoma, you should consider it in the neuroretinal rim. I don't mean cup disc ratio. Cup disc ratio is no more used as indicator of glaucoma. However, it gives you an idea about the progression of the disease. But for the confirmed diagnosis, neuroretinal rim is more specific for glaucoma. This slide show the component of the RGC complex, that's the retinal ganglion cell complex, which made up of three components: the retinal nerve fibers, the ganglion cell layer, and the inner plexiform layer, as you can see in this slide. So these are very important in the measurement in the OCT to determine confirm the diagnosis of glaucoma, as well as to determine the progression of glaucoma. Now, because the retinal nerve fibers are very thin in the area of the macula, now recently they just concentrate on the ganglion cell as well as the IBL, what's called GC IBL complex, instead of including the retinal nerve fibers in this area. Among the points that I want also to speak before we start reading the OCT map is that because of the OCT is very sensitive machine, and the speed of the OCT very important factor in determining the resolution of the image, we get confronted with the problem of the artifacts. There are some artifacts that you should exclude before reading the OCT map, and these artifacts are very crucial in giving a proper diagnosis of the patient. If you mistakenly read the map without concentrating in the artifacts, you might get stuck with a false positive or false negative results. These artifacts can be subdivided into three categories: patient-dependent artifacts, or operator-dependent artifacts, or device-dependent artifacts. We will go quickly through these artifacts, either in the media or diameter of the pupil, or motion artifact, or in the operators or in the device. We will go quickly through these artifacts. So the operator dependent artifacts the acceptance of the image with poor signal strength. One of the most important things that before you give a diagnosis after reading the OCT map, look to the signal intensity or signal quality. If the signal intensity and the signal quality is poor, you have to repeat your exam. Don't jump to give a diagnosis with a poor quality OCT. And this signal intensity is very important. Why? Because the OCT is not directly measuring the thickness of the retinal nerve fibers directly, but it measures it indirectly through measuring the reflectance of the rays from the retina. So based on these impulses or signals that's reflected back, it gives you the thickness. There is a direct proportion. So if the reflectance rays are good, you will have a good thickness of the retina. If the reflectance rays are poor, you will have poor thickness of the retina. So if your image quality is poor, you will definitely find poor thickness, and you will wrongly diagnose glaucoma, which is called a green disease, that is, or red disease. That is, the patient is normal, but you wrongly diagnose him as glaucoma. So this is an operator artifact. Among the things, that's the truncation of the OCT image due to blinking. When the patient is blink, there will be cut of the image, and this will affect the reading of the OCT. So if you find any truncation artifact, you have to repeat. Another thing is the improper retinal nerve fiber layer segmentation. That is the place where you take the OCT. It should be very clearly seen and without any segmentation artifacts due to any abnormalities like pre-retinal membranes or bleeding or anything. So this is another important things. Among the operator-dependent artifacts include the truncations, as you can see in this image, in this patient, in the upper left side. The image is not properly taken and is taken outside the acquisition window. So part of the nerve fiber layer at that area is cut. So by mistake, it gives you an error red area, as you can see, that this patient has thinning of the retinal nerve fibers at that area. But actually, this is not. This is an artifact due to a truncation error. So by repeating the image of the same patient, which is seen in the lower part, you see the thickness is normal and everything is normal. So this patient has completely normal.
The common artifact and the anatomical variations can be due to the artifact like imaging problem. As I mentioned earlier, the scan quality and the signal intensity should be very clear, good, and the segmentation errors should be very clear. There is no poor segmentations, and some variables due to the patient himself. For example, medial opacities, presence of any vitreoretinal interface problems, and presence of optic nerve drogens and myelinated nerve fibers. All these things can affect the interpretation of the finding of the OCT map.
OCT. As usual, before speaking on OCT map or everything, you should memorize this image that gives you the histological appearance of the retinal nerve fibers and the clear resolution and very high resolution of the image, and the different thin layers of the retina, starting from the nerve fiber layer, ending up with the retinal pigment epithelium and the different nuclei. You can see the different zones and the hyperreflective zones of the nuclei, either in the gangliocell layer or the inner nuclear layer or outer nuclear layer, and the hyperreflective zones seen in the external limiting membranes and ROS, inner segment, outer segment interface. So you should memorize this image before studying the OCT. Now we will start with the first steps in reading the OCT map. Generally, what we are looking for in the OCT map, there are two things that we are looking for: either the RNFL and ONH optic nerve head disc cube, or the ganglion cell analysis macular cube, what's called macular cube. So you have to read whether your patient, you are dealing with the optic disc cube or the macular cube. In the optic disc cube, there are about 7 maps inside. The thickness map, then the deviation map, then the calculation circle, Tisnet map, RNFL quadrant or clock hour graph, neuroretinal rim, and the extract horizontal vertical B scans and the K parameters. And the same thing will be repeated for ganglion cell analysis or macular cube, the same thing. So this is the general categories of the map of the OCT that we will go one by one through each one of these maps. Here in this slide, I want to speak about the different color codes that's used in the OCT map. There are three different color codes used in OCT map. The first color code is the red color here, which is indicate the thickness or the pachymetry map. Here, the hot colors, that's the red and yellow, indicate the thickness. The more the red, the more the thickness of the cornea. This is a pachymetry map or thickness map. The other color code is the yellow or the orange one, which is called the reflectance color code, which indicate the structure, whether it is hyporeflective or hyperreflective. This is called the reflectance code. The last thing is the statistical color code, which is indicate the deviation of the data from the as compared to the normative data. So green color, the hot colors is the green. Green indicate normality, and as there is a deviation from beyond the normal range, you will find the yellow and you find the red. Now, the importance here that you notice that the thickness map or the pachymetry map is opposite color code as an opposite color code as compared to the statistical maps. That's the deviation map. Okay, this is very important to not misinterpret the color code. Now, the thickness map, the hot colors is the red. Red indicate normal. However, in the deviation map, red indicate abnormality. Now, in this patient, in this slide, I'll speak about the different color codes of the probability plots or probability maps. When you find your patient falling in the green area, what's the meaning of the green area? Indicate that between 5 to 95% of the normal population lies in this area. So most likely your patient is normal if he's in the green zone. However, if he's in the yellow zone, he still has a chance of 5% to be a normal. That because 5% of the normal people also lie in the yellow zone, but there is 95% chance that he's abnormal. Similarly, if your patient fall in the red area, there is less than 1% chance that he is normal, but there is 99% chance that he is abnormal. This is the meaning of this color code. This is very important to understand the finding when you find your patient in the yellow zone or the green zone. Now to explain more about the this color code for the probability, suppose that we have a group of this is a basketball team, and we make a study on the toll of each one. Now, if you can see here that between 5 to 95% lies within the green zone. This is the normal range. That is 9 to 95% of these people falls in this green zone. However, another 5% of the normal people also falls in this zone, but this is deviation from the 95%. So if your patient fall in this area, there is a chance 5% that he's normal, but there is a chance 95% that he's abnormal. Now, still there is some category lies in the red area. There is less chance to be normal. That's only 1% to be normal. However, 99% chance to be abnormal. And any patients or deviation beyond this red, this is most likely that this is definite abnormal. This area beyond the range, and they are definitely abnormal. This is the meaning of this color code. Exactly as we said earlier. Now, this is the first slide for the how to interpret the OCT map. As I mentioned earlier, you have to concentrate in the upper paragraph in the age of the patient, name and age, and right and left eye, and the most important parameter is the signal intensity. Signal intensity should be normal, and the signal intensity, it varies from machine to machine. For example, in Zeiss it should be more than 6, the signal intensity. Other machines should be more than 10. If you have poor signal intensity, you shouldn't interpret the image, and you should repeat your acquisition of the image, because there is a direct relation between the poor image quality or signal with the thickness of the retinal nerve fibers. So what are the factors that lead to poor image signals? Number one, as I mentioned, a patient artifact or problems include the cornea. For example, dry eyes, patient with refractive errors or vitreous opacities. High refractive errors will give you a poor signal intensity, and also when there is a small pupil, this will gives you a small poor quality of the image. So it is mandatory to dilate your patient before you do your OCT. So you can see here in this picture that this patient's taken a picture of the OCT with poor signal intensity around 5, which should be normal more than 6. And you can see here the difference between the, if you look to the thickness map, the upper pole of the optic disc is red, no, it's okay, but the lower part is not symmetrical with the upper part, so it gives you an impression that this is abnormality. And when you look to the deviation map below it, also there is red and yellow superpixel colors, which indicate also that there is abnormality. When you look to the neuroretinal rim, also there is depression, and thin nerve fiber layer thickness, there is abnormality. All these findings will give you what's called false negative, false positive, which is the red disease. But actually, this patient is, because of the poor quality of the image and poor signal intensity, he has this finding. When they repeat the image with the good signal intensity, more than 6, you can nearly see all these things has been disappeared, and look to the clearly to the thickness map, and the deviation map is completely normal. So from this point, it's important to have a good signal intensity before you go ahead with the interpretation of the OCT map. So it's very clear that the signal to noise ratio and the image quality is very important for the interpretation of the retinal nerve fiber layer thickness analysis. And a minimum 6 is important for Zeiss, and other machines they need more, I think. Among the artifact that I mentioned earlier is the truncation artifact. This is a truncation artifact in the right upper image. You see clearly that the data is missing from this area. So that reflected on the deviation map. Now the upper one is the thickness map, which shows the black color. The lower one is the deviation map. It gives you the hot colors of the red and yellow, which indicate abnormality, which is really not a real abnormality, but this is because of the truncation factors, like this. This is the area of red, and this is the truncation map. So this is, you should take care of these artifacts. Now we'll come to the first map that we read in the OCT. That's the thickness map and the deviation maps together. So the first one is called the Ahrenfeld disk cube, or the deviation map. The upper image is the thickness map, which is, this is just the raw data, the raw data that we collect from the patient after taking the picture, after making sure the signal intensity is good and everything is good. So this is the raw data. It gives you a quick impression about the thickness of the retinal nerve fibers around the optic disc, and gives you opportunity to compare between the upper wedge and the lower wedge of the retinal nerve fibers as they converge to be inserted in the optic nerve. And the lower picture is the deviation map. This is after applying the statistical tests to know whether the deviation or this raw data is deviated from the normal or within the normal range. What I want to say that the first image is the raw data. That's only the data without any statistical application. Now, if you have this raw data, you cannot say that this is normal or abnormal unless you compare it with the normative data that is stored in the machine. So after comparing the data from the patient with the normative data for his age and his refractive error and his 6, now the deviation map in the lower part, which appear as gray in color, this image gives you the deviation. Now you can see in this image that he has redness in the lower infero-nasal part or inferotemporal part of the optic disc. So this indicates that there is thinning or abnormality here. So you can see in the thickness map here up there is difference between the upper and the lower, but we cannot say that this is statistically significant unless we look to the deviation map below. So we know that this is the redness and this is the abnormality. So this is the importance of the first map. The other maps is the extracted horizontal and vertical tomograms. These maps is important to look for it to know whether the segmentation is good and the location of your OCT is good in relation to the optic nerve in the horizontal and vertical plane, and you look to the shape of the cup and if there is any abnormality in this area. This is the extracted horizontal and vertical map. This map is the shows you this is called the Tisnet map. Tisnet map that we take the picture of the retinal nerve fibers around the peripapillary area from the temporal to the inferior to the nasal, then the superior. Tisnet map. Okay. So it shows combination of both the right and left eye, one dotted line for the left eye and the straight line for the right eye. And you compare this with the normative data of the patient. We'll come in details with each map of these. I am showing you the different parts of the map, but in details I will take one by one. As I mentioned, the other part of the map is the lower part. This is the segmentation or iron-filled circular tomogram. It's called iron-filled circular tomogram. This map is very important to know whether your segmentation is normal or not. Yani, whether you have taken the image exactly in the good place or not. So you have, before you interpret, you have to look to your segmentation. Because if your segmentation is poor, so you have to repeat your image again. For example, you see this, there is in the lower part, there is abnormality here, there is pre-retinal membrane here, so the segmentation is not proper in this area as compared to the other. Here, there is an artifact shadow in the right side, so the segmentation is poor. This will be reflected back into the other maps. So like this patient, you have to repeat your image again. We will take one by one. Here, the first map here, we say that this is the thickness map and the deviation map. This is the two most important maps in the OCT. That is the thickness map and the printout of the retinal nerve fibers, the raw data, and the deviation after applying the statistical tests to determine if there is any deviation from the normal. For example, in the deviation map showing the red area over the inferotemporal sector, indicating that the pixels are below the first percentile of the normal value, suggesting that they are most likely abnormal. This is the inferotemporal and superior temporal fibers. Inferotemporal fibers always the most vulnerable to glaucoma. So if you have changes here, it indicates that your patient is suspected to have abnormality of the optic nerve. So if you compare the upper arm and the lower arm, definitely there is a difference, but you cannot say that this is statistically significant unless you compare it with the deviation maps. In the deviation map, there is slight difference here, but it is not clear. Now in this image, it is very clear. Now this is called superpixel of the deviation maps. In the raw data, for example, 200 by 200, this is written as 200 multiplied 200 pixels, indicate 200 A scans in the vertical axis and 200 scans in the horizontal axis are taken and gives you this raw data. Now this raw data, every 4 A scans are converted to 1 A scan, so it gives you an image of 50 by 50 superpixel. Now the colors here are significant. The red color indicate that there is a deviation more than the 1 percentile of the normative data. So this is an abnormality, and your patient has thinning of the nerve fiber layer at this area. Among the things that you have concentrated in the thickness map is the symmetry. The symmetry between the upper arm and lower arm, and the symmetry between the two eyes. It gives you an appearance like a butterfly wings, So if there is any abnormality in the symmetry, also indicates significance. So it's important to look for the symmetry. And this is only the normative data. We don't speak about the deviation map yet. So you can see exactly here the symmetry between the upper and lower, as well as symmetry between the two eyes. Now the deviation map, which in the green squares or rectangles, this is after applying the statistical tests to determine whether the abnormality or the deviation of the raw data is beyond the normal range or within the normal range. As you can see, it is highlighted with red and yellow superpixel. So this is indicate that there is deviation from the normal, and this patient is abnormal. So this is the importance of the deviation map, which is an InFAS image, infrared image of the database comparison overlay. Regions thinner than the 5% will appear in yellow, and areas thinner than 1% of the percentile will have a red superpixels. Always inferotemporal and superotemporal are more indicative of glaucoma, especially the inferotemporal part. As I said earlier, this is the image after magnification with superpixel. Now the next map, which is the TISNet map. I should remind you here now that we have isn't rule and we have the TISNet map. Isn't rule saying that the thickness of the neuroretinal rim is maximum in the inferior and the superior part. That's isn't I for the inferior, followed by the S superior, followed by the nasal, followed by the temporal. Isn't rule. This is important in when we study the deviation map of the neuroretinal rim, the map above this one. Okay. But now this map is studying the nerve fiber thickness and the peripapillary area, an area of 3.4 millimeter around the optic disc. So this is called TISNet map. It means that we take measurement from the temporal side, then the superior, then the nasal, then the inferior, then the temporal side again. And this map is plotted against the normative data. The two eyes are represented in the same map, so that the straight line for one eye and the dotted line, as you can see here in this eye. Now you can see in this image that in the inferior part of the optic nerve here, the straight line that representing the right eye is dipping into the red area. So there is thinning here in the inferior part. And as I mentioned before, that the most vulnerable area, the macular vulnerability zone, is the inferior pole. Always, glaucoma will start thinning in the inferior pole, followed by the superior pole of the optic disc. So now here, this is significant that there is dipping of the thickness of the nerve fiber layer at the inferior pole here of the optic disc. So this is called the TISNet map, and both eyes are represented in the same map. So this map is centered, the main crucial point of this map, that it should take the location of the optic nerve properly, which is centered around the Broca's membrane. Now, in the next map, that's the neuroretinal rim, we will explain how to measure the neuroretinal rim exactly, and explain how we take the thickness of the neuroretinal rim. Now, this map, the same, is called the TISNet graph neuroretinal rim. The same thing, but now we are speaking on the neuroretinal rim, not on the peripapillary area. And this, we compare the thickness. Is it obeying the isn't rule or not? That's, you find the inferior part is of the optic disc is more thick, and that followed by the superior, followed by the nasal, followed by the temporal part or not, or if there is any deviation from the normative data, so we can see if your patient is at risk or not. As I mentioned, this map, it's important to locate the location of the optic nerve properly, and we take the thickness of the neuroretinal rim based on what's called the Broca's membrane to minimum width principle. That's from the termination of the Broca's membrane up to the termination of the internal limiting membrane. The line connecting them is the minimum width distance. I will explain in details in the next slide. So this slide shows exactly how we measure the neuroretinal rim. The termination of the yellow line is the termination of the Broca's membrane, and the red line is the termination of the internal limiting membrane. The green line in between is the neuroretinal rim.
In this slide, you will see how we do measurement of the neuroretinal rim of the optic disc, what's called as broadcast membrane to minimum rim width measurement. As you can see here, this is the termination of the internal limiting membrane, and this is the termination of the broadcast membrane. The distance in between is regarded as the neuroretinal rim width. Now we come to the fifth map, that's the R-and-fill quadrant and the clock hour map. This map, you can see the area around the optic disc is divided into clock hours, around 12 sectors, or quadrants into 4 sectors, and it is exactly based on the deviation map, shows you the defective thickness of the retinal nerve fiber layers. The yellow color here represents that 5% of the normal population here, and this patient is suspicious to have thinning in this area. So it is a P chart or P graphs shows the R-and-fill thickness analysis, vulnerable to misinterpretation, and can hide small dents in the TISNET map. It is related to the TISNET map, and compared to the age and disc size matched with the normal. So this is a deviation map compared to the normative data. The fifth or the sixth map هي ال K parameters اللي هو ملخص the summary of all the findings in the map. You will find it here as far as the cup disc ratio, neuroretinal rim, retinal nerve thickness, and so forth. This is the key map. So I would like to emphasize here that the cup to disc ratio is not a sensitive biomarker for glaucoma. We are not using it in our diagnostic evaluation, but with OCT, we can quantify the rim width with reference to the broadcast membrane opening. That's the broadcast membrane to the minimum rim width. We can determine the cup, but it is not important biomarker here in the OCT. The most important is the neuroretinal rim.
The seventh map is the extracted horizontal and vertical B scan, which is dotted here in the red square here in the right side. This map shows you the reflectance of the segmentation that you have taken, and you will get an idea about the exact shape of the optic disc cup and the shape of the optic disc, and if there is any artifact or abnormality attached to the disc, you can see it here, so that you can interpret the finding of the neuroretinal rim and thickness based on the appearance of the optic disc here. So if there is any artifact or any abnormality can be seen. For example, you see here the dipping and the shape of the cup in the horizontal and vertical view. So this is called extracted horizontal and vertical B scan. The next map, the eighth map, is the lowermost one, which is dotted in the green rectangle, which is the R-and-fill calculation circle. This is the R-and-fill calculation circles. It shows you the segmentation, the portion that you have taken in the retina. Is it normal? Is there any artifact? Is there any abnormality or irregularities? It will be seen here. For example, here, this is the segmentation is very good. So you can make a diagnosis on the data above. So it is important when you look to the OCT map, you look to the signal intensity and look to the segmentation first. If the segmentation is good and there is no artifact and the signal intensity is good, at that time you can go ahead and proceed with the interpretation of the data available. Finally, I want to remind you of the average thickness of the retinal nerve fiber layer thickness. Normally, it ranges between 95 plus minus 11, and in early glaucoma below 80 is regarded as early glaucoma, and in advanced glaucoma up to 50. And in the next slides, we'll come across a new terminology which is called the floor effect, the floor effect of the OCT. By floor effect of the OCT, that the thickness will be fixed beyond the thickness of between 50 to 40, like this. There will be no further reduction in the thickness, even the glaucoma is progressing. This is called the floor effect of OCT. That's why OCT is useful in early stages of glaucoma in the follow-up and detection any progression. However, in advanced glaucoma, OCT is not much useful, but visual field is more useful in detection for the progression of glaucoma, and that's because of the so-called floor effect.
Artifacts. Now, one among the important things that I would like to speak about the correspondence between the retinal nerve fiber thickness map and the retinal nerve fiber thickness deviation map. There should be a correspondence. What I mean by the correspondence, that as I told you before, that the color code, this is the thickness map, and the hot colors indicate normality. However, the hot colors in the deviation maps, that's the red color, indicate abnormality. Here there is thinning in the superinasal and inferinasal. So when we look to this map, you will find there is discrepancy between the thickness map and the deviation map. So there must be something wrong. Actually, this usually happens in cases of high myopia, in which the superinasal and inferinasal arcades of the retinal nerve fibers, they converge early to be inserted in the optic nerve. So leaving the normal location of the arcades here a little bit thin, so as if there is thinning of the retinal nerve fibers. And the reason why, because in the cases of high myopia, more than -7, the OCT data, the normative data of the OCT, there is no normative data for cases of myopia beyond 7 or -7 or -8. So if you, by mistake, you don't write in the OCT when you put the information of the patient that your patient is myope, so the normative data, where the OCT will interpret the image with the normative data. I mean, with normal patients without myopia. At that time, this artifact will appear, which is named as a false positive or red disease. What I mean by red disease, that the map shows you the redness, that there is a disease, but actually your patient is normal. This is peculiar to cases of high myopia. So you should take care when you interpret the map of a patient with high myopia, that you should introduce the refraction properly in the machine. And you can note this discrepancy between the thickness map and the deviation map. So when you find such artifact, you should repeat your OCT. So the correspondence between the arcades in the thickness map and the deviation map is very important, and look for the symmetry. Normal thickness map and abnormal deviation map usually seen in high myopia, where the eye gets elongated. So the temporal and inferotemporal fibers will converge early on the disc, leaving an area of thinning in this position. Now, when we repeat, now this patient, the earlier one, this is the myopic patient, has been compared with the normal patients, with the normative data of the patient. So this appears red. Now, when we reintroduce the data of the patient and we write that he's a myopic patient, so the machine will compare it with a myopic patient. Now the picture appears green and appears normal. So this is one of the common mistakes that usually seen in OCT, which is called red disease or false positive. Now we finish the optic nerve cube. The same thing we will repeat in the ganglion cell analysis. That's the macular cube. The same thing we will repeat. The reflectance map and the thickness map, color code, and the statistical color code, the same thing. But now on the area of the macula, So the same thing in the macula, we have the thickness map and the deviation map. The thickness map, the hot colors, the red indicate normality and the normal thickness, and the deviation map, this is after applying the statistical tests. So that shows you whether your patient raw data is deviated from the normal or within the normal range. And here we use the statistical colors. You see the red color means that less than 1% chance that your patient is normal, and the yellow color that less than 5% chance your patient's color is normal. You can see clearly here that there is defect in the temporal part here of the macula, and this is normal, and the other eye is normal. And this is the segmentation map. Okay. Here I would like to emphasize to make sure about the artifact and the anatomical variations. Always before you interpret the OCT map, you should make sure that there is no artifact in your image, as well as keep in your mind the anatomical variations. So the machine has no brain, and you should use your own brain to interpret the image. So in this next slides, we will speak about some of the artifacts that commonly happens, and by mistake, it might wrongly be interpreted. For example, what's known as floor effect of the OCT. The floor effect that the current segmentation algorithm almost never measures retinal nerve fiber thickness less than 40 or 50 microns. Some machines up to 50 microns, some machines between 30 to 40 microns. So if you look to this OCT map here, in the left eye, the dotted lines is borderline is just above the red zone, and even the disease is progressing, it will not be dropped more than this. So if by mistake you find that your patient has zero thickness, that is the thickness here in the map, and then is zero, or here in the TISNET map is zero, this indicates that there's something wrong, and it might be due to an artifact. And that's why we say that OCT is not useful in advanced glaucoma for follow-up the progression, because the disease will keep on advancing, but still the thickness, there is some thickness on the nerve fiber layer. It gives you an impression that the patient is not progressing. So this is one of the important things that you should keep in mind, the floor effect. If you find the thickness below than 40, so just keep in mind the floor effect of the OCT. Among the common anatomical variation, what's known as split iron fill. That is, there is splitting of the arcades of the retinal nerve fibers as they converge toward the optic nerve. As you can see here in this image, you find the upper arcades has been split into two parts. And this is usually seen in cases of myopia because of the elongation of the globe. The arcades of the retinal nerve fibers tend to split into two bundles before they converge to the optic nerve. So you can see this anatomical abnormalities or anatomical variation. You should keep it in your mind. The other thing, when you look to the TISNET map here, in the TISNET map, you can notice that the apex of the retinal nerve fibers has two hump appearance, and they are deviated. So this is due to splitting of the iron fill. The other thing is the temporal shift of the iron fill. Also, this is a common anatomical variation that commonly seen in cases of high myopia, that there is deviation of the converging rays of the retinal nerve fibers beyond the normative data. As you can see here in the TISNET map, the apex of the thickness is deviated from the normative data. The normative data here in the green, and the apex is deviated here. And so there is deviation or shift of the iron fill. This is commonly seen in cases of high myopia. As you can see in the arrow here, the apex of the thickness is deviated from the normative data, that is the green. So you should remember this anatomical variation. So the thickness good, but the curvature does not coincide for the normative data. He has normal thickness, but the appearance of the elevations is deviated from the normal, as you can see here. Another artifact or abnormality, what's called the red disease or the false positive. Red disease, it means that the image appears red, that's abnormal. However, your patient is normal. As we mentioned before, this can be because of the artifact. For example, when you look to this map in the left side, there is an artifact here due to detachment of the vitreous, which is called the Wiss ring. And this is make a shadow in your image, dotted in the black color here in the thickness map. And this is reflected back into the deviation map by this red area. And when you look to the TISNET map, you will find that there is deviation to zero. The left eye, the thickness has been reached up to the floor here, which is abnormal. As I told you that OCT will not measure up to zero thickness. So when you find this deflected back to the zero, this indicates there's something wrong. With the Wiss ring has been displaced to another place, you will find completely normal TISNET map graph, and the deviation map is good. So there is no any redness here. So this is called false positive or red disease due to Wiss ring. So you should keep this in your mind.
Green disease, what's meant by green disease? In a green disease, when you look to the OCT map of the patient, you will find all the parameters of the patient's falls in the green zone area. However, the patient has a disease. For example, if you look to this patient, if you look to the this segmentation map, you will find undulation of the segmentation, and this is because of vitreoretinal attractions. And this segmentation leads to irregularity on the surface of the retina. When you look to the thickness of the Tisnet map, you will find the right and the left eye, as you can see here in the red arrows, they fall in the red zone, or in the green zone, I mean the green zone area. Also, the quadrant map and the clock hours graphs also all falls within the green area. However, when we extend our map to the macular area or macular cube, you will clearly see that there is a significant disease with the thinning of the nerve fiber layer of the area of the macula. And also in the visual field, you can clearly see that there is changes in the visual field. So this patient has a significant disease suggestive of glaucoma. However, his parameters are within the green area. This is called false negative or green disease.
Other anatomical variation is the presence of myelinated nerve fibers. As you can see in the fundus picture here, he has a myelinated nerve fibers. When you look to the thickness map, you see the extensive red color around the optic nerve here, which indicate that there is a retinal nerve fiber, myelinated nerve fibers. You should keep it in your mind.
Here, I would like to emphasize on that there is an annual rate of decay of the retinal nerve fibers. So there is around 2 microns per decade. Per decade means per 10 years. So there is 2 microns loss per 10 years, around 0.2% per year. This is very important to keep it in consideration when studying the thickness map. Another point that the inferior quadrant is very resistant to the age decay. So any thinning in this area should be taken seriously. So when you follow a patient with glaucoma suspect and you find any changes in the inferior quadrants, you should take it seriously. So this is very important to keep it in your mind when studying the OCT map. Another point that I want to stress on is the large cube retinal image, the central 30 multiplied 25 degree. This is called the ATDRS grid or ATDRS map, as stated by the ATDRS study. That's the early treatment diabetic retinopathy study. This is very important to understand this map exactly, that it is made up of 3 concentric rings. The first ring within 1 millimeter diameter, and the second ring within 3 millimeter diameter, and the last outermost ring is within 6 millimeter diameters. And the inner ring and the outermost ring further divided into 4 quadrants. So a total we have 9 areas within this area of the macula. Now, when we study this area exactly with the OCT, it shows that the macular thickness within the first millimeter ring is around average 229 microns. However, the mean macular thickness, what I mean by the mean macular thickness, I mean is the average of the thickness of the macula within these 9 quadrants or 9 zones is around 269 micrometers. And they found that the thinnest area, which is the central part, is within 1 millimeter ring, and the thickest area is within the second ring, that is within the 3 millimeter ring. However, the thickness will be decreased as we go toward the periphery. So this is named as ETDRS grid or ETDRS map. So we have 9 sectors and 9 zones, and when we want to describe any pathology, we have to describe it based on this map. Any area outside the ETDRS zone is called area outside ETDRS zone, and this is within the ETDRS grid. Now we reach to the summary for all what we have said previously. And I need you to take home message that the average ganglion cell to inner plexiform layer thickness in a normal subject is around 82 micrometer plus minus 6, And the thinning of the GCIBL due to normal aging, there is an annual rate of decay which is around 0.3 micrometer per year. And the average GCIBL thickness is in early glaucoma is more than 75 microns, and between 64 plus minus 8 is moderate glaucoma, and if it is less than 60, that's around 55 plus minus 7, it's indicate advanced glaucoma. So we can stage glaucoma based on the thickness of the GCIBL thickness. And the annual decay of the retinal nerve fiber layer thickness is around 0.4 to 0.6 per year. So you can see that the annual decay of the retinal nerve fiber thickness is more than the annual decay of the same retinal nerve fiber at the ganglion cell area. That's around 0.3 micrometers. And the thinning of the retinal nerve fiber thickness suggestive of glaucoma progression globally and sectorially. So if there is a progressive increase in the thinning of the retinal nerve fiber layer, it indicates progression of glaucoma. بهذا أعزائي الطلبة نكون قد انتهينا من الجزء الأول من محاضرة Interpretation of OCT in Glaucoma. We try to cover many aspects regarding the definition of glaucoma and the introduction of the different types of OCT available in the market, and the principles of artifacts and what are the principles of interpreting the OCT maps, and certain important points related to the subject. Now the next, or the lecture, or the part 2 of the same lecture regarding interpretation of OCT will be concentrated on the OCT angio and the recent advances in glaucoma imaging techniques. We will meet in the next lecture, and I hope you will enjoy and get benefit from this lecture.